Okay, good morning, good afternoon, good evening. I am going to do the voiceover PowerPoint for diabetes, which is chapter 45 of your Pearson textbook. Obviously, the chapter itself is not that long in sense of pages, but the PowerPoint component of this content is roughly 76 slides. But I'm going to touch on every single slide to go over it because there are no instructor notes, if you will, at the bottom, so I think it's pretty important. Diabetes is a huge disease, if you will, being our concept for metabolism for this week's content. Diabetes tends to be the forefront of comorbidities, which basically means diabetes is never a serve-alone disease. It always encompasses and causes other serious concerns physiologically. So if someone's a diabetic, you most likely will see that they have cardiovascular disease, peripheral vascular disease, at risk for strokes, complications obviously related to diabetes. So I think it's pretty critical to your nursing practice, both as a student and as a registered nurse, that we talk about this content pretty closely and get into some of the medications. What you will see from the voiceover PowerPoints I am able to do for this course, I don't just focus on the drugs. I focus on the pathophysiology behind the exemplar, nursing process, nursing interventions. We will talk about prototype drugs. As noted in the chapters, it's just, I kind of believe in the holistic approach to nursing and not just teaching you about glucophage, for example, or what is glucophage, what does it do, why is it considered the gold standard in oral diabetic agents, how does it complement short and long-acting insulin, things of that nature, so that you can kind of put a big picture together when you're evaluating your patient. You know, when you potentially would not give insulin based on a blood sugar reading. Someone who's NPO or nothing by mouth and they're diabetic, think about they're not getting carbohydrates and sugars. Carbohydrates that break down into sugars, which fancy word for that is glucose, also glucagon, which is your body's natural production of sugar, if you will. So it's very important that we look at all those components and not just go past meds without looking at the whole person, patient, client, and being able to establish a critical thinking intervention based on your patient's presentation or your patient's scenario. Next slide. So let's just start a little bit with the pathophysiology. If the pancreas is working, it produces insulin, and so therefore you're not going to be a diabetic. And they call it the islets of Langerhorn. And there's other hormones that feed into that, but the pancreas has so when your blood glucose increases, all right, and your pancreas is working to its full ability, your pancreas will release insulin to counteract the amount of sugar in the system. And it's technically what you want to call homeostasis. It kind of keeps your body in a nice metabolic balance when it comes to insulin and glucose. All right. There are other hormones and drugs that can affect the blood sugar. We're not really going to talk about adrenal insufficiency or thyroid conditions such as pituitary gland. I think the focus is primarily on the straightforward diabetic patient without looking at other hormones, because that adds more concepts and exemplars to the picture. But just be mindful that your adrenal gland and your pituitary gland and your thyroid gland are the hormone big station in the body, and so they do have a play in affecting blood sugar, and certain drugs do as well. So we'll get into that a little bit, but we're really going to focus on the standard type 1 diabetic and then a type 2 diabetic, and we'll separate those out when we get to those components. Next slide. That's going to come from your alpha cell, okay? Next slide. And so that goes to the liver, and that breaks down the glucagon, returning glucose to the blood. And that's why metformin is such a beautiful, best starter oral anti-diabetic agent on the market, because metformin or glucophage is metabolized in the liver, okay? So by doing that, it's restoring glucose to the bloodstream without causing hyper or hypoglycemic signs and symptoms for the patient. That's why it's a beautiful drug. And we'll get into that shortly. Next slide. All right, so type 1 diabetes, as sort of alluded to, absolute lack of insulin secretion, autoimmune destruction right out of the gate. They haven't really, it's just like the body says, I don't like the pancreas, and we're not using it. I mean, that's probably basically as much as I can put it. Pancreas is just not, don't like the pancreas, or shutting it out of the system. It's, you know, not happening. But if left untreated, of course, these children, young adults, end up having severe problems because they're hypoglycemic, and usually you end up very quickly, or hyperglycemic, excuse me, that you end up very quickly, these patients end up in the hospital, and that's when they get diagnosed. But if you don't monitor it, and you're not consistently on top of it and being proactive, that's what I talk about, that brittle condition. It ends up where you've got cardiovascular disease, peripheral vascular disease, neuropathies, all kinds of huge issues. And you'll see when we get into perfusion, especially with hypertension and myocardial infarcts, those are what some of the comorbidity diseases I'm referring to. Peripheral vascular disease, diabetes will never be really a standalone in these older people. As they get older, they will have complications, and they'll be more severe if their diabetes has not been well maintained, and they're not abiding by also lifestyle changes. As nobody should smoke, I get that. But these folks are more at risk if they are a smoker and a diabetic, because it increases the cardiovascular damage, because smoking does cause damage to the cardiovascular system. And the double whammy is adding untreated diabetes to that. Nervous system damage, so it's retinopathy. So think retina, which is your eyes, and people, let me just backtrack so you can put a mental image in your head. Sugar is a very large crystal. Okay, it's a very large crystal, and if you think about the diameter of your vessels in your body, the vascular system vessels are very small. So what ends up happening is that there's too much sugar in your system that's not controlled. It starts damaging the blood flow to those areas. So retinopathy, if you've got too much sugar, it's destroying the vessels that feed your eyes with the oxygen and the nutrients they need to work. So what ends up happening is you destroy those vessels and those people go blind. Okay? Same thing with peripheral vascular disease. When you think peripheral, what is the furthest digit away from your heart in your whole body? Your feet, your toes. Okay? So vascular disease, the same principle with the large sugar destroying the vessel wall itself. People lose oxygenation and nutrients to the feet. So what ends up happening? The tissue dies. So ever hear the word gangrene? That's where your amputations come into play, because you don't have the nutrients and the oxygen to keep the tissue alive, so it dies. So you can see amputations, bilateral above the knee amputations. It causes huge long-term complications that increase morbidity in these people. So if you think of someone with a bilateral knee amputation, what don't they have anymore? They don't have their legs. So if they don't have prosthetics and can't afford them, what are they sitting in? Wheelchair, a chair, a bed. So what happens when we don't move them often enough, or teach their caregivers or themselves? Pressure ulcers. So you can see how this starts to spiral completely out of control. Okay, so just think of the bigger picture. Okay, it's not just about giving drugs and giving insulin. You have to think more about what's going to happen if not properly and effectively treated, and you need to teach this to your patients so they understand what could potentially happen if they don't take care of themselves. Because when they go home, they're no longer within the four walls of the facility that you're working in. They're now back out in the community. And if we don't do our job teaching while they're in our facility, reinforcing it upon discharge, they will be back. They will be back either on your floor or another floor. Next slide. Type 2 diabetes used to be historically would hone in on people in their 40s and older. Unfortunately, with the increases in obesity in this country, we're starting to see type 2 diabetes in our adolescents. And basically, the insulin, the pancreas is working, but the body is resisting letting the insulin into the organs it needs to go into. And they call it a defective insulin receptor. Trying to think of the best way to describe this. Type 2 diabetes tends to affect people who are overweight. And I hate the word. The more layers of tissue in the an overweight person reduces the ability of the insulin to cross over into the bloodstream so that it can be perfused, if you will, to other organs such as your kidneys, your liver, your heart, your brain, your feet, your legs, the whole kit and caboodle. We're seeing the type 2 because of the obesity in our younger adults. Again, historically, it used to be a diagnosis in people 40-ish and higher, but now you're seeing both type 1 and type 2 in your adolescent population. Your pancreas is working perfectly fine, but now it's on overdrive 24/7 every day of the week. So it's constantly exceeding. It's working overtime to produce even more insulin, but that's not the problem. You can produce all the insulin you want. It's just not able to transfer into the cells of your body. So eventually the beta cells die. And so, then all you've got left of it are your alpha cells. And that's not just think about how that works in sense of the mechanism of your symptomatology for hypo and hyperglycemia still exists for type 1, type 2, but the physiology between type 1 and type 2 is different. And then again, you're seeing more type 2 people who are adolescent because of the increase in fast food consumption, lack of exercise, hate to say it, being on mobile devices, being on PlayStation, there's less exercise going on, less activity. Students, are sitting in classroom all day, go home and sit on their iPhones, Facebook, Twitter, play their video games. They're not getting the activity they need, and then they've increased their carb intake, which I said breaks down into sugars. So there you go. You can see how the spiral's out of control. So eventually you have deficiency in the insulin secretion because we destroyed the beta cells, and then you add the insulin resistance. So these folks could potentially be on the same regime as the type 1 because you end up with the same problem. Okay, and then you also have to incorporate the lifestyle changes with both type 1 and type 2 diabetics. It's not just about drugs and medications. Next slide. So as I said, if treated with a healthy diet and exercise, insulin resistance can be reversed. So you put them on an appropriate carbohydrate diet, you get involved in exercise, walking 20 minutes a day, 5 days a week, things of that nature. You can reverse it, but the longer you wait, the more at risk you put those beta cells to be completely destroyed, and it's a done deal. So as I said, if left untreated, type 2 results in the same chronic conditions as type 1. Just understand the etiology is different, but you end up with the same problem if you left untreated. Next slide. Signs and symptoms. All right, so what we talked about with fasting blood glucose, and I said, your facilities may have between 70 and 110. We start looking at that 126, they start calling that hyperglycemia. The more brittle a patient is, regardless of type 1, type 2, you may see these symptoms occur quicker and more frequent. So polyuria is a fancy word, or the medical terminal word, for increased urination. Polyphagia is thirst. Polydipsia, I forgot polydipsia. Sorry, I'm having a brain thing. That's increased thirst. Polyphagia is increased hunger. Glucosuria, obviously high levels of glucose in the urine. Fatigue and weight loss would apply to type 1. Weight loss you see sort of over the long term, but as I said, hyperglycemia can come on quickly, or as I said, people can sit there in the 200s and don't feel crappy. It just depends on the patient's physiological, and every patient's presentation technically could be different. So let's just talk about, like, if someone comes in, they are a diabetic, you do a blood sugar and it's 220. What I would do as a nurse is I'd get a urine sample. It can be a clean catch, just pee in a cup, I'm good. And then you take a dipstick, and on that dipstick, you can do a multitude of things. You can pick up whether someone's spilling ketones, which would indicate potentially urinary tract infection. Remember, your white blood cells, like your leukocytes, if that lights up like a Christmas tree, that's a UTI. But glucosuria, that's where you're going to see the high. People should not be spilling, if you will, quote unquote, sugar in their urine, because what the body's trying to do is get rid of that excess sugar, that glucose. So they're doing anything they can to dump it, and they're dumping it in the urine. That's not a normal finding. The only thing normal in a urine culture is no bacteria, no blood, no sugar, no ketones, an appropriate pH, no bilirubin. Okay, you should have and it should just say white blood cells negative, blood negative, ketones negative. You want to see negative across the board. When you start seeing positives, you start looking at other things. And since we're only going to focus on glucosuria, if there's glucose in their urine, that's telling you something about whether that patient is type 1 or type 2, and definitely something's going on because it's now starting to affect the kidneys. Now think about this. Remember when I talked about that large molecule of sugar destroying the retina, causing blindness, causing severe peripheral vascular resistance to the feet, potential for amputations? What's happening at the kidneys? Same thing. Microvascular glucose molecule is too big, it's destroying the tissue and oxygenation to the kidneys, kidney failure, dialysis. See where I'm going? Renal failure. So again, diabetes is not a standalone. It always is going to encompass something else that could be life-threatening to that patient. Next slide. All right, we kind of touched on this, dietary restrictions. If you're in a facility and the patient's a type 2 diabetic and they're, you know, I hate the word frequent flyers, but if, you know, they keep coming back month after month, every 3 months, every 6 months, and getting admitted, that means their diabetes is not in control. And if you're not really clear on what's considered dietary restrictions or what a good diabetic plan would be from a food stance, get your dietitians that are employed in your hospitals to come do a consult. That's their job. Use your collaboration, use your experts, use the teamwork, okay? And then you consult with him or her, and then you can get the diet changed with the physician and try to start to get things under control, and then the dietitian can start the education, and that at least is one start. Exercise, I said that before, and insulin therapy may or may not be with an oral agent of other anti-diabetic agents. Okay, so it's like I said, lifestyle changes, not just pharmacology and drugs. Next slide. All right, so insulin preparations vary. I'm hoping you got some of this in Nurse 111, but if you're on page 767, table 45.1, this is a note card table, okay? So make a note card or take a picture. I don't care how you study for it, but you have to know. You have to know it because you're going to be a nurse, a registered nurse. Okay, you have to know when a doctor orders Novolog that's a rapid acting, and then it's going to hit that patient in 15 minutes, and with 1 to 3 hours it's going to peak. And that means when it peaks, it's having the best effect of reducing the sugar in that patient's body, and it's going to be in their system for at least 5 hours. So let me throw this out at you. You come on at 7 o'clock in the morning, you get report, you're working a 12-hour shift, you have a CNA or you're designated to do it, you do a fasting blood glucose, and they're 160. And they'll have an order for insulin rapid. Your Humalog, which you're probably more familiar of hearing. Even your regular insulins. You know, that's short acting. But think about it, the doctor orders, I don't know, 5 units of Humalog to be given 15 minutes before breakfast. Obviously, they'll be on a diabetic diet. Then the doctor turns around at noon. So what time is it? It's 8 o'clock. Okay? Checked the sugar, gave him the insulin, got the breakfast. But at noon, there's another order from the doctor to administer another 10 units. But what's wrong with that order? The duration's 5 hours on that med. So is that a med error? Yes, if you give it, and yes on the doctor's part. So you please try to understand that I'm not being picky about this, but you need to understand the duration, the onset, and the action. All right, that's why it's so important. And then for administration, insulin is given subcutaneous. There are pumps out there for insulin, people who are type 1, for example. So their pump is set to give them insulin on a regular basis per the doctor's prescription, and the patient is the one that's fully knowledgeable, we hope, that knows how to use the pump and is aware of signs and symptoms and can work with the pump if they're not feeling well, or if they're sick. That's going to increase hormones and stress, which would increase stress levels in the body, and that could increase sugar, and that therefore they may need more insulin. All right. So yes, the other one you'll see a lot is the last one on the bottom. That's Lantus. That's long acting. There's no peak. It's in their system for 24 hours. So if you see Lantus ordered twice a day or BID, is there a problem with that? Yeah, because Lantus should be ordered once a day. So for your nursing knowledge and your patient care and safety, you need to know this table. And I don't mean just to know it for my course and know it for an exam. You need to take this with you when you go out into the real world. This is critical. Okay? So make note of that. All right. So that's kind of where this slide comes into. And there's a picture of an insulin pump, for example. They're all different. There's tons of different pumps out there. It kind of works best with the patient, and it's subcutaneous. But besides listening to me, make sure you read the chapter as well, so that I'm not going to go through every single piece, but I want to go through the big parts, and that's why PowerPoints are driven to pick up on important stuff. Well, there's your picture. So that's a beautiful thing. So it comes right out of the book. So you've got it visually, you got it visually in the book. But it's important that you understand what 3 drugs are rapid, what 1 drug is short, your intermittent drug, which your Novolon, and then your Levemir and your Lantus are the 2 long-acting. And that currently is what's out there. Not to say something else won't come down the pike at some point. But make sure you're also working and understanding compatibility. All right. Next slide. I'm not really going to get too much into this. I mean, you know, this doesn't play a huge role, if you will, in the world of understanding insulin administration from a nursing practice standpoint and patient safety. But it is a human insulin. So that's kind of what you need to know from that. Fewer allergies, less resistance, more effective. And like your Humulin R and your Novologs, for example, and Humulins, some of these are really old, have been on the market for decades, and have been proven to be effective. So you'll see them a lot in your facilities where you're employed. Next slide. So basically, the prototype drug that's first discussed here is on page 768, and that's your Humulin R or your Novolin R, and that's your human regular. And regular is your rapid. So that's where that sliding scale comes into play. People will be on NPH, people can be on Lantus, and if they're not getting the kind of control they need, they may be taking short-acting just to kind of counterbalance it. Again, I'm not trying to be specific, but it will be specific to the patient and the patient's presentation. The bottom line is that you understand its actions, administrative alerts, the onset, which is your pharmacokinetics, which is also the peak and duration. Be aware of the adverse effects. Just think about someone with a sugar of 70. And let's say you missed something and you didn't check, and the doctor ordered they get Lantus in the morning. Some facilities give Lantus in the evening. But then you're supposed to give, I don't know, 5 units of regular. So think about how your patient's going to present within 1 to 3 hours of that administration. Just think about it for a minute. Actually, 30 to 60 minutes, excuse me. Just think about what's going to happen. It's going to be the same thing you're going to see with hypoglycemic side effects, right? Because what you've done is you've dropped the sugar when they're already sitting at a low level to begin with. So they're going to sweat. They're going to get confused. They're going to get hungry. All right? They're going to lose some orientation. They're not going to present well. Check a sugar. Always check a sugar. I don't care if you think the patient's having a stroke. Check a sugar. All right? That's the first and foremost. Even if they're not diagnosed as a type 2 diabetic. If they're not alert and oriented, they're confused. Like I said, they're hungry, they're lethargic, they're drowsy. Check a sugar. 10 out of 10, I wouldn't say 10 out of 10 times. I'll bet you 80% of the time the sugar's low, whether they're diabetic or not. Okay? So contraindications, just be familiar with, you know, those pieces of it, and then the interactions between drugs. And when we get to ACE inhibitors with hypertension, this will come back into play. And if you look at the far right, kind of where it says interactions in red and drug, ACE inhibitors will refer more to your renal drugs that help control hypertension from a renal standpoint. And there are drugs out there for hypertension that work directly off your heart. Calcium channel blockers, beta blockers. Your ACE inhibitors are the drugs that end in pril, P-R-I-L, captopril, lisinopril, acupril. And so you got 2 components for that. So just be familiar with some of those drug interactions. I don't really talk too much about lab tests. The potassium would play into play for DKA, but that's second level for you. So we're just not. I just want you to understand your insulin components from this prototype drug. All right, next slide. Kind of covered this already. This is coming off of your what I just talked about. As I said, emergency management for ketoacidosis, and effects, of course, are hypoglycemia. Next. All right, so this basically covers prototype drug on page 768. So it's just reiterating what we just talked about. Next slide. Gestational diabetes. Does everybody know what gestational diabetes is altogether now? No? Okay. Gestational diabetes is a woman, obviously, who is pregnant that may or may not be a diabetic, okay, but somehow during the pregnancy becomes a diabetic. These women tend to deliver very big babies, like 10 pounds over. Um, so it doesn't mean that the infant's going to be a diabetic, and doesn't mean mom's going to stay a diabetic. It just occurs during the pregnancy, which is why there's so many testings. Like if you've had children, you have to go through a not blood glucose. You have to drink this god awful sugar mix at some point during. I'm not an OB nurse, so just bear with me. But you do have to drink. They do a 24-hour sometimes, and maybe they do another one later in the pregnancy. But what it does is you drink this really sugary, crappy drink, and then within a period of time, they check the pregnant woman's blood glucose. And if it's really elevated when it shouldn't be, because the pancreas should have already secreted the insulin to reduce the sugar in the body, and it stays really high, that's when that gestational diabetes diagnosis can come into play. Then they really start watching mom and the baby more closely. They kind of consider a little bit of high risk. If the sugar reading is between 70 and 110 after you drink that god-awful drink, you're good to go. But that's why they have you do that, because for some reason with the body during pregnancy, whether the mom's a diabetic or not, sometimes the body just can't manage the pregnancy, and somehow some response from the pancreas, and then they have to be watched and monitored more carefully. But I don't cover that piece of it, because you get that really heavy in 113 with OB and labor and delivery. Next slide. I think this slide is pretty self-explanatory. The only thing I want to talk about is rotating injection sites. It's pretty important that you have to rotate, and you teach your patients to rotate, especially if they're new diabetics, and that this education is a lot. Because if you keep using the same sites, what ends up happening is you can develop, you can not destroy the tissue, but you can end up with, I can't think of the word coming off the top of my head. It's not going to happen. That'd be embarrassing, standing in front of you all talking about that. It's not well absorbed if you keep using the same injection site. It's like it toughens the tissue, and therefore it's not getting absorbed. So patients need to rotate their sites. Now it's subcutaneous, so the most common sites are usually your abdomen. Don't go anywhere near the belly button. Stay away from scars. Stay away from previous incision sites, because think of scar tissue. You're not going to get well absorbed. If you have scars on your body, feel them. Feel how rough and hard they are. Now think about putting insulin in that. It's not going to go anywhere. So just think logically a little bit about that. So always rotate your injection sites, and then when you discharge them, make sure they understand how to rotate. They say they do. Ask them to explain it to you. Have them repeat the directions to you so that they know that they heard you correctly. Or have them practice on themselves, especially if they take insulin at home. Even if they don't take insulin at home, but they're now on insulin upon discharge, please teach them how to draw it up correctly. Make sure they can see the syringe correctly. Make sure they know that the orange cap on a syringe is dedicated only to insulin. Make sure they use alcohol pads, because they're going to have to do this at home. If they don't do it at home, guess what? They're going to come back in with DKA, right? Right. Minister approximately 30 minutes before meals, and again, that's reference to the regular. Okay. So a lot of information, but like every slide is going almost through every single paragraph here. Adverse effects we've talked about. If it is gestational diabetes, the labor and delivery doctor will be the one calling the shots on how he or she manages the gestational diabetes for the pregnancy. And unless you're in labor and delivery nurse, you probably won't see this in a med-surg unit unless there are more complications to the pregnancy. But usually these folks end up in specialty floors that are specific to labor and delivery. Drugs, we talked about this. We're really going to focus on the ACE inhibitors. The MAIOIs are antidepressants classification. We're not covering depression in 117, but there are some psychiatric concepts and exemplars in 114. The MAOIs are really old classification of antidepressants, so just be aware with the ACE inhibitors and the MAIOS. And I can't pronounce it, so we're just going to use the capitalized words. We'll talk about your diuretics, which is basically patients in congestive heart failure, too much fluid on the lungs, too much fluid around the heart, too much fluid in the abdomen, lower extremities. We put them on diuretics. We'll talk more about that when we get to congestive heart failure, and then the playback into the renal drugs with the ACE inhibitors for cardiac complications. Next slide. So lab tests, again, I usually do a urine just to make sure. Just to make sure they're not spilling sugar. I mean, that's pretty critical. I mean, just do a urine and check a sugar if you think something's up, even though they're not a diabetic, potentially. One student had asked if I was going to talk about herbal medications. I unfortunately don't have the time in this course to do that. I'm not saying it's not important, but I thought for a 7-week course, technically, of content, it would be valuable to focus on oxygenation, metabolism, and perfusion and infection. I think those are the biggies in the med-surg world. But just to kind of feed back into that, complementary and alternative therapies, regardless, across the board. Pharmaceuticals do not like herbal medications and vice versa, because there's not enough research out there that specifically captures all your alternative and complementary therapy medications to say whether it enhances the pharmacological drug or decreases its effectiveness. Some research has established, for example, like people who are taking garlic or ginseng may potentiate the hypoglycemic effects of insulin. So when you're doing a med list with folks, don't just ask them what they're taking that's prescribed. Gather information on what they're taking over the counter, which would be herbal, so that you can put those pieces together. And so the herbal foods, if you will, that have been addressed with human regular is the garlic, bilberry, and ginseng. And people are using more herbal medications as we go. So again, if nothing else from this slide, make sure that you at least capture all the herbal medications and over-the-counter meds people are taking, so you get your pharmacological picture. Basically, if you have hypoglycemic effects, people should have oral glucose available if it's mild. If it's severe, you'll do IV. And why would you do IV versus oral if it's severe? Because your fastest route of administration is intravenous, because it's the whole body, right? If you take it oral, where's it got to go first? Stomach. Then where's it going to go? Small intestine. Then where's it going to go? Gallbladder. Then where's it going to go? Liver. Large intestine. See how slow that process is? If I give it to you IV, where's it going? Everywhere. At once. Okay? See the difference? So severe, IV, oral for mild. And check a sugar frequently, especially if you're giving them glucose, because you don't want to send them where? Hyperglycemic. Okay? Next. Insulin administration, kind of covered this. It's subcutaneous generically across the board. Can be given IV depending upon the severity of the patient's presentation. Only regular insulin can be given IV. Everything else is sub-Q. And what did I just say? If I have a severe hyperglycemic patient, what do I want? Do I want Lantus? It's going to take 24 hours. Could be dead, right? So let's give it rapidly and give it IV. Reverse complications ASAP. Just think about it. Makes perfect sense, doesn't it? Next slide. I showed you the pump on the page, so we're just going to move along. Hypoglycemia, we got that. Insulin overdose, improper timing, skipping a meal. Exercising without eating. You're an athlete. You go out there, you forgot your granola bar and your Gatorade at home. You start running your track, and you're a type 1 diabetic. You're in trouble, right? Because what's exercise do? It's eating up the sugar that's needed for the energy for you to run. I think that's pretty logical, wouldn't you say? All together now. Yes, Dr. Sporber. All right, hypoglycemia, we've touched on this. Sweating, tachycardia. What's tachycardia? Medical terminology for fast heart rate. What's fast heart rate? What's normal? 60 to 100? So what's tachycardia? Greater than 100? What can happen if my heart rate increases so fast? Can I end up with an irregular heartbeat? Yep. What could that do to my heart? Cause a problem? Chest pain? I'm listening. Alternative EKGs, you'll see that when you get to 212 and 211. This will come back into play. Confusion, drowsiness, obviously severe convulsions, medical terminology for seizures, coma, and death, which obviously nobody wants. We got that. That's pretty self-explanatory. Next slide. All right, so again, they're calling the hyperglycemia greater than 126. Polyuria, polydipsia, polyphagia, glucosuria, weight loss and or gain, and fatigue, which we've covered already. All right, so as a nurse, be familiar with onset, peak, and duration of action of prescribed insulin. Please, please, please understand, not just to understand it for this course and to pass those questions on the exam. You got to know them just for safe, ethical, legal practice. Okay? Think about the big picture. Next slide. All right, make sure you know your compatibility. Again, that's on that table. That's pretty important, okay? So I'm not going to review this because we've gone through it ad nauseum, and you'll hear me say that a lot. All right, this is going to go into the nursing practice, and I've covered a lot of this already. So I just really want to be mindful. You get your potential nursing diagnosis. I know you do some care plans in 111. I'm not sure about 112. You don't have to write care plans for me, but at least it gives you, this book gives you understanding what nursing diagnosis potentially could be, and that's based on your patient's presentation. So all this slide's really doing is supporting, you know, what you can do as a nursing care plan. And I think care plans and facilities at this point are pretty standardized, and that means you're not making your own up. You're just pulling out the one that's particular to your patient, and make sure you individualize it so it's just not typed out for a generic population. You might want to add things to it after you review it, and you'll get that in your orientation when you're hired as a nurse. Since I said the word when, not if, when. All right, so baseline assessment, I've already talked about the health history, disease, pregnancy, drug history, over-the-counter drugs, allergies, I should say, it should be a no-brainer. Herbal preparations I talked about. Do they smoke? Do they drink coffee? How much alcohol do they use? We'll get to medications where alcohol affects the ability of the insulin, the ability of the diabetic drug to even work in the first place. You always got to get a health history. Always got to do a head-to-toe. Always got to put your face in the patient's face and talk to them. Don't use medical terminology. They're not a nurse. You are. Well, they could be a nurse, and that might be better, but let's just say they're not. Assess the feet and lower extremities for possible ulcerations. You want to get a dietary history. Want to know what kind of fluids they intake. You want baseline vital signs, height and weight, and BMI. Does everybody know what a BMI is? That is assessing whether a patient's obese or not in the BMI world. Okay, so those are very important components to gather that entire holistic upfront picture of your patient, especially if you're the admitting nurse. You're going to have to do this anyway, and this is just for one exemplar. What if they come in with CHF and they have a history of hypertension and they've already had a heart attack and they've already had open heart surgery? I'm not trying to blow your minds out of the water, but I guarantee you that all of that would be a culprit from diabetes. Period. You will find diabetes someplace in that diagnosis of all, especially when you see a slew of cardiac issues. Okay, so be mindful of the assessment piece, and the nursing diagnosis is really just for your learning of it. But that, I'm not really focused on that. I'd be more focused on the baseline assessment. Next slide. Yeah, bottom left, lipodystrophy. So what's happening with your lipids, which is your fats, if you will. You got good fats and bad fats, and you want to make sure people have an appropriate management of their fats. And if they've already got a history of what's called hyperlipidemia, which is this elevated cholesterol in the body, that causes cardiovascular problems too. But then you start destroying, or dystrophy, start changing the shape of the lipids is going to increase and worsen the lipid panel, which would increase the potential for what happens when my big highway is feeding oxygenated blood to my heart. What happens when I start building up roadblocks of lipids? Big roadblocks. What am I losing to my heart? I know you're saying it out loud, oxygen. So what happens to the tissues, like what's happening to my toes? Tissue does what? Starts to die, causing chest pain. Not fixed, not corrected, gets worse. What happens? Heart attack. See where I'm going? Diabetes, lipids. Okay? Think about it. Let's go forward a couple slides. That one. We've talked about this. Alright. Bulleted item, left box. Here's your A1C, CBC, electrolytes, glucose, lipid. Talked about that. Hepatic and renal function studies. What's your hepatic? What's that medical term for? That's your liver. Or as my nurse practitioner instructor used to call it, a lever. So I always thought she was referring to a bar of soap, but it's liver. English was not her first language. And I'm not making fun of her, but I couldn't figure out what she meant by lever. But I figured out eventually. So you can see how it's multifaceted. And the A1C level provides a measure of glucose control over several months. On typical average is 90 days or 3 months. All right. lab work should be done periodically. And if a patient is uncontrolled, I'm digressing. If a patient has uncontrolled diabetes, make sure they have an endocrinologist who specializes in diabetes. Okay, not just a PCP or general practitioner. You know, these people who are uncontrolled and get more and more brittle really should have an endocrinologist as well as their general. I call them PCP, primary care providers. All right, not the other PCP. That was supposed to be a joke. If you didn't get it, that's okay. But laughing and humor in nursing school are critical to sanity. Next slide. You guys got this. You know, we've talked about this a lot in the last hour or so. So this is just, I love the fact that this textbook really picks up a bunch of stuff that's really important. I would have liked to seen probably less slides because I think you can kind of get the fact that it seems to be a little bit redundant. Redundant's good. I don't mind it at all. But I think we've captured a lot of this already. All right, I'm going to keep going. Just read it through because it just reiterates what I've already talked about. And I'm not skimming through any of this, but we've talked about it, and I don't think it needs to be considered continually rehashed, if you will. Talked about this. Yeah, see, when you said then the site of the lipodystrophy. So that's part of that scar tissue, the lipid problems, the functionality of your lipid panels, etc. Ensuring proper storage of insulin. We didn't talk about this. Unopened insulin may be stored at room temperature, but avoid direct sunlight and excessive heat. Once it's open, it needs to be stored at room temperature for up to a month. I've seen people put them in the refrigerator, but think about, like, if you have really sensitive teeth and you drink a really, really, really cold glass of water with ice, what happens to your teeth? They start to burn. It's uncomfortable. So think about injecting ice-cold insulin into somebody. So room temperature is probably less of a shock to the patient's body, and especially into that site subcutaneously. Again, constantly educate your patients because the expectation when they go home is that they can effectively manage it and they're not coming back to your facility month after month or month after month. We always encourage patients to wear diabetic alert bracelets because if they're found unconscious, all right, either hypo or hyperglycemia, and I'm not laughing because of that, but if they don't have an alert bracelet, your EMS people aren't going to know it's necessarily diabetes, especially if it's like an unwitnessed fall, for example. They fell down because they have low blood sugar. So having a diabetic alert bracelet or having some identifying documentation in their wallet, like an ID card that says I'm a type 1 diabetic or type 2, that gives the EMS people right out of the gate the first intervention. Check your sugar, see what it is, go from there. And so that just please encourage your people to get it if they don't already have it. As I said, I think it's just critical to getting interventions implemented quickly. So we got that. Patient-centered care, interventions and rationales, proper storage of insulin, subcutaneous injection sites, always inject at a 90-degree angle. Don't use the same needles. People who, let's say, have little to no money may save reused needles. Please don't. Make sure they use a sharps container at home. If they don't have a sharps container, you can use a detergent bottle that's really thick plastic, like a Tide bottle, where they can dispose their insulin syringes. And so then you want to wrap it up with heavy-duty tape, like the black tape or the I can't get it, the silver tape, and then write on it sharps container, so that when they dispose of it in the garbage, your garbage people who pick up your garbage don't have the possibility of getting a needle stick. I mean, just think about it that way. They should never be sharing needles. They should not be reusing needles. Teach them how to properly. They want to recap. You teach them how to recap. A lot of times they'll just drop the insulin syringe after they've injected themselves into the either the sharps container or a really durable, thick plastic laundry detergent. I wouldn't use a bleach bottle because they're usually thin plastic. But that's they can recap, but then they run the risk of sticking themselves. They don't have to wear gloves when they do it themselves. It's their body. I'm trying to think what else. Rotating sites, using of alcohol prep pads, avoiding scar tissue sites. Don't go near the belly button. That's about it. Oh, I know. If they're obese, for lack of a better word, subcutaneous. Think about the layers of your skin. You have your epidermis, and then you have your subcutaneous. Cutaneous is skin. So sub is below your epidermis. So 90-degree angle, they may have to pull up a bit of their abdomen tissue, if you will, to make sure. Remember how small the needle syringe is in length? It's pretty tiny, isn't it? Tiny and thin, but it's not very long. So if they're a large person and they only get that needle into the epidermis, where's it not going? It's not going in subcutaneous. So how effective is the insulin going to be? It's not. Okay, so just think about that. So you want to lift a little. If they're really skinny, like really thin, you know, you want to spread out the skin a little bit for a 90-degree angle so we know it gets in the subcutaneous. So just some nursing intervention words of wisdom, I guess. All right, next. Oh boy, type 2. All right, we got this. We talked about this. Type 2, we have to the second little line, treated with oral hypoglycemics, and that's probably going to take us to table 45.2. And you're probably looking at that page and going, oh my. So, preprandial blood sugar. What does that mean? Preprandial, before breakfast. Postprandial, after breakfast. All right. So we want to check a sugar before they have breakfast, so we know what their baseline is. That's like with our congestive heart failure patients. We want to weigh them daily. We want to weigh them daily in the birthday suit and the same time every morning, so our variables don't change. So we know if we got weight gain on board or not. They're doing an A1C of 6.5%. Should be or less, not of less. I cut it off at 7. I'm sorry, I read the slide wrong. You want your A1C to be less than 6.5. So Pearson's probably saying from a textbook standpoint they'll medicate after 6.5, but I've seen when I was doing nurse practitioner schoolwork and precepting nurse practitioners, we usually start at 7.0, but every physician's office may start at 6.5. So I'll just leave it at, you know, well, let's just say for consistency with the textbook versus real world practice, let's do 6.5 and higher. Okay, we'll start oral agents. And you want your so you want your, when you wake up in the morning, you want a sugar of 110. So again, between 70 and 110 is normal. And the classification, I guess, they're going to assume hyperglycemia is going to start at 126. Even though you won't see sliding scales from physicians implemented much before a patient hits a blood sugar of 200. Next slide. Okay, before we even get into this, all right, what I really want you to take away from this, all right, at some point in the future, this page for me is 773, table 45.2. So don't shoot the messenger, but you are going to have to know the classification. So let's look at the top one: alpha glucosidase inhibitors, precose, and glycoset. All I want you to know is how it's delivered. What's the route? PO. Because for now, for your education, okay, that you know that oral anti-diabetic agents are what? By mouth or PO. But you are going to have to know adverse effects, because this is going to affect you clinically as a student and as a registered nurse. The next one is your metformin, and that, as I said, was the gold standard. It's metabolized through the liver, so it's not going to affect glycemic levels. People won't get hypoglycemic from taking it, and that's why it's a beautiful drug. Because when the liver does is it gets metabolized in the liver to reduce the release of glucagon. You're with me so far? So it limits the release based on the amount of it's a beautiful drug because it doesn't cause hypoglycemia. But let me ask you this: think outside the box. If it's specifically mechanism of action is through the liver, what do I want to know about my liver before I prescribe the drug? I want to make sure my liver is working, right? So I want liver function tests, or LFTs. And you'll get to that when you get to 211, when you start looking at metabolic panels and blood work. If I have, let me just think about this for a minute. If I have a chemical, I'm not going to try to blow your minds here. If I have a chemical that's elevated, that my liver is supposed to be normal, it may affect whether the provider puts that patient on glucophage. Because what happens if my liver is not working at full max potential? That medication's a waste of time. It's not going to get metabolized correctly. So you have to make sure that liver function tests are technically within normal limits. Okay. You got your GLP agonists. These are a lot of the new drugs you see on TV right now: Trulicity, Victoza, Byetta. Please know how they're getting, what their route of administration is and their adverse effects. You'll see Tradenta, Januvia is new, Starlix is new. I'm just working my way down the line. Sulfonylureas. So I want you to know whether they're PO or sub-Q and their adverse effects, please. Your Actos and Avandia are really old drugs, but they're still very effective, and since they've been proven on the market, they're pretty good drugs. So if you know the adverse effects, if you're looking at a lot of these adverse effects, stuff that's underlined, like what you see in a drug book, is severe, and things that are italicized are frequently seen. And if someone's had a history of myocardial infarction, if you look at Actos, or they're in heart failure, you really want to see the doctor give them Actos when they've got a diagnosis of congestive heart failure. All right. So please recognize the route of administration and the adverse effects. Okay. I'm not going to hold you to how many times a day do you give it, what's the dosage, blah blah blah. Could I? Sure. If this was a 16-week course and I could do diabetes over 2 weeks, which would be the beautiful thing, then we could focus our time on this. But I'm limited to 7 weeks in a 2-credit course. So as your instructor for this course, I think the value is recognizing the route of administration and the adverse effects. I would like you, for your real-world experience, to have some type of understanding of the max dose that's allowed so that you can monitor. I'm not saying physicians are incompetent, but if I were to hold you for this course, then you would know, if you go back at the top of the page for pre-course, that you could not give more than 300 milligrams a day. In this course, it's relevant, but I can't hold you to that. But you need to hold yourself to it, please, so that you don't make a med error, or you can catch the doctor before he or she makes a med error. Next slide. So we're just going to keep going because I've already covered this in the table of the book. And the miscellaneous drugs, Cycloset and Welchol, I've never even seen them. What I talked about is sufficient for what you need to know. Selected combinations. Well, all right, that makes sense. They've got a lot of new drugs out that they're actually comboing now. The one on the bottom is the most frequent that I see, that's the glyburide and metformin. In other words, instead of giving a patient a glyburide and metformin, the pharmacology companies have been able to put the two drugs together to figure out how to get the max benefits out of both. All right, so that's basically what this slide is saying, is that the brand name is, and then on the middle of the page, generic drug, that's the combination. Like you've got metformin with I can't pronounce how I won't even say how I got through nursing school. The P word / metformin, they've figured out how you can put it in combination. So that's just more information. You might see some of this in the facilities, but those are what they've started to do for combination drugs. Now I think the prototype for metformin is what I really want to focus on, so I'm going to keep moving. Causes, classes, that's in the previous slide, that's covered in the table, so that's not anything different. Alright, so what's interesting here is what this PowerPoint slide is going to show you is the sulfonylureas, which, as I said, was the Emeril, Glucotrol, Micronase, Glinase, Diabeta. These are really old drugs, but they're a good second generation. Releases insulin from the pancreatic islet cells. So, what kind of type diabetic do they have to be? Your Jeopardy kind of going on in the back of your brain. My pancreas is working, so what am I? Type 2. All right. So it's increasing the sensitivity of insulin receptors on target cells. Target cells just being the cells of your body where it needs to go. Of course, any oral anti-diabetic agent is always going to set somebody up for hypoglycemia, except for metformin / glucophage. So obviously, you can get hypoglycemia. Too much medication increases the insulin production, drops sugar, or patients aren't eating 3 meals a day, or they skipped a meal. So I think we've kind of covered that ad nauseum. Here's your glucophage. Okay, so what it does is, as I said, it increases production of the sugar and reduces insulin resistance. It has nothing to do with the pancreas. So what type diabetic am I? Type 2. Okay, as I said, usually the first line of therapy, usually tolerated very well. One of the major side effects of metformin that's common is GI disturbance, as in like diarrhea. Like patients can't I almost said can't stomach it, but that's technically correct. No pun intended. GI disturbance, diarrhea, can't manage the drug. It's out there, it happens. People will end up coming off of glucophage. We try to give it a couple of weeks. We usually start them off 500 milligrams BID if we're going to do glucophage by itself. Or if we're going to do the combo drug, we might do 15 milligrams / 500 to 850. But from that, usually the biggest disturbance is diarrhea, and they just can't tolerate it. Then we have to go to Plan B. But most people can. But we try to give them a couple weeks for the body to get used to. If that doesn't happen, we got to go to Plan B. So understand the major side effect of metformin glucophage. But that's your prototype drug on page 775. And that's going to go through the same prototype combo language that we had for insulin, the regular. So I probably, let's just go to the next slide and see what it looks like. Yeah, here's the most side effects, minor and GI related. Sometimes the diarrhea is not minor. And then to think about diarrhea, if they're not doing, what's happening? They're going to get dehydrated because diarrhea is primarily water. Okay. And as I talked about the extended release formulation of metformin with glucometza, which I don't think I talked about, but that's once daily dosing. That's new to the market as well. It's still the same. It does the same thing. It still has the same mechanism of action. So just those are out there, and just be mindful of them. Yeah, preferred oral antibiotic managed type 2. Its effectiveness is safety. It can be used alone or in conjunction with insulin and other anti-diabetic meds. It is approved for children over the age of 10. It's available as regular release. Extended XR stands for extended release. As I said, it works in the liver. Make sure your liver's working. Next slide. Major advantage, as I said, doesn't cause hypoglycemia, stimulates insulin release. So it works over a period of time. Also helps with LDL, triglycerides, the good and the bad. That's a beautiful thing. Can help promote weight loss, not always proven. And women with PCOS or polycystic ovarian syndrome, metformin is considered what's called off-label. In other words, you're not a diabetic, but you have PCOS, you can go on metformin. Because it doesn't cause hypoglycemia, but it helps reduce the symptoms of polycystic ovarian syndrome. So that's a beautiful thing. When I say off-label, it was not its original intended use. All right, they just found, oh, look at that. We can treat metformin with this reproductive female, I hate the word disease, situation. That's not a good word either. But that's what I mean by off-label. Lowers insulin, helps with hormone levels, and helps definitely restore normal menstrual cycles and ovulation, which can be very painful, frequent, distressing, amongst other things with PCOS for women. Okay, this is something I don't know if you picked up in 111. Sustained release tablets have to be swallowed whole. Can't crush them, and they can't be chewed. So if someone's on a G-tube, if I got a G-tube, NG-tube, excuse me, nasogastric, what am I bypassing? My mouth. So I'm getting my nutrients, my fluids, just tap water because it's not sterile, and it's not IV. Can I crush a sustained release tablet? No, because what happens with a sustained release? It goes to the gut, but it's not released until, again, it's pharmacodynamically supposed to go where it's supposed to go. So if you crush it, it loses its efficacy. All right, and some of that language, I'm hoping that by the time you get to this PowerPoint, you've already read chapters 1 through 5, and you figured out the mechanisms of how certain drugs work in certain parts of the body based on the route of administration. You want a blood glucose level obtained every 3 months, and have the doctor adjust doses accordingly. If any signs of acidosis occur, discontinue. Pregnancy category B. All right, women who are pregnant, drugs will be classified on pregnancy A, B, and C. As I said, I'm not an OB nurse, but this basically says whether that medication can be used with a woman who is pregnant. And since I'm not an OB nurse, I was hoping, let's see where it is. Hold on, you can do the Jeopardy tune in the background. Okay, category B is using metformin caution with patients, and this is under contraindications under pregnancy. All right, so used in caution, I would leave that up to the obstetrician or the OB doc to figure that out. Here is your onset, peak, and duration. You need to know these. Same reason you need to know them for your insulin, because you need to be checking sugars frequently. All right. Make sure you know the difference between 1 to 3 hours for regular release and 4 to 8 hours for extended release. And then the duration for the regular, with its not extended release, is 12 hours, and for the extended release duration is 24 hours. So remember when I said the extended release and you combine them with another medication, instead of giving it 2 times a day, now you can give it 1 because it's going to last for 24 hours. Beautiful thing. Next slide. Here's your adverse effects. Talked about that. Black box warning. All right, lactic acidosis is very rare, though it could be fatal. This condition will increase in patients with renal insufficiency or any conditions that put them at risk for increased lactic acid production, such as liver disease, which is why I said you got to get a LFT, liver function test panel. If they've got severe infection, alcoholic use, shock, or hypoxemia, which is low oxygenation. So that's a black box warning. So you have to do, let's go back to renal insufficiency. Diabetic type 2, kidneys are crapping out, pardon the language. So you do renal panel, and that's going to give you a bunch of lab values, which you'll get in 211. So if their kidneys are on the fritz and they may be going on dialysis, is this the best drug of choice? Probably not. Why? Because it could cause lactic acidosis. Maybe you've heard of acidosis when it comes to respiratory and metabolic acidosis in your acid-base imbalance class from 111 to 112. So now I'm talking organ acidosis. Okay, so but think about the complications of metabolic acidosis and respiratory acidosis. I've got acid. What's happening to my pH? I'm not alkaline. I'm not homeostatic. I've got a pH of 8, 9, 10. Think about it. Does the body like acid? No. Acid's a nasty word. Just think about all the connotations to that. Next slide. So I just kind of covered that. Contraindication patients with heart failure, liver failure, history of acidosis. Yep. Didn't know about the IV radiographic contrast. It doesn't tell me why, so unfortunately can't help you with that, but I can research it. Anemia, having really low red blood count, diarrhea, vomiting, dehydration, fever, gastroparesis, which is what's called dumping syndrome with patients who are type 1 and type 2, where your stomach is just not absorbing and digesting food correctly. And that's a GI complication of diabetes. I did focus more on cardiac and renal and neuro. GI obstruction, hyperthyroidism, we're going to leave those two items alone because I'm not bringing in adrenal insufficiency and Cushing syndrome into this course. Pregnancy I touched on, and obviously in older adults, just because as we get older, what happens? Things start to slow down. I may have a beautiful liver and a beautiful kidney, but as I get older, they get older. So I could have problems that are unrelated to the disease processes. I may be just not able to excrete well because of kidney issues, and I may be not able to have my liver metabolize as well as I'd like to. So we have to think about the older adult because things get old as we get old, okay? Which is why you should do lab tests, the moment they walk in your door. Hold on a quick second. I have to answer an email. My apologies. Maybe I won't be able to do that. I can't toggle back and forth. If I lost you for a second, I'm back. So just because I would have to be a problem. I think this here's her herbal food stuff. Metformin decreases the absorption of vitamin B12. Garlic and ginseng. So you're seeing some similarities with your human and regular. So we're in good shape on that regard. Treatment of overdose, hemodialysis. Basically, you've got to clean the blood out, clean the acid out of the blood to make it as straightforward as I can. Go back a slide. Especially if it's working within the stomach for breaking down complex carbohydrates and monosaccharides, which is your simple sugars in a fancy word. So that's how the digestion of sugar is delayed. So usually well tolerated. If you're going to have side effects, it'd be GI related, correct? The hypoglycemic does occur, so treat with glucose, not sucrose. It's always glucose. Some other ways and mechanisms that your glycosomes work. This is pretty self-explanatory. This can go on your note cards for your drugs, okay? This would be what? What diabetic am I? Type 1? Right? Type 1 or type 2. Okay? Short durations, actions 2 to 4 hours. So again, these are really old drugs. They're very well tolerated, and you can see a common thing that hypoglycemia would be the most common adverse effect. This is going to go back to more of your hormone releases that help stimulate the insulin secretion and stop the glucagon production through the liver. This decreases the gastric emptying, increases sense of fullness, maybe used as an alternative if metformin or sulfonylurea. Monotherapy means only one drug at a time. It's ineffective. So basically all these slides are doing is giving you the mechanism of action and the possibility that you could see them in combinations depending on your patient scenario and the prescriptions that the doctors put these folks on. So this kind of is a little bit more in depth with it, but it's in the tables, so don't get too overwhelmed. Just be aware of these medications. So the Paralodol is fairly old, but they're using it. It was approved for type 2 treatment in 2009, marketed as cycloset, and that's under your other miscellaneous. And it's still unclear, so I can't tell you what the exact mechanism of action. Does it work on the pancreas? Does it work on the liver? Does it work on the gut? Don't know. This is self-explanatory. Obviously, physical exam, health history, psychosocial history, lifestyle history, labs, medications, including over-the-counter, herbals, etc., labs, your renal panel, your liver panel, your CBC, the whole kit and caboodle. Make sure you get that all in assessment. I said this 1,000 times before. Ketones is not normal in the urine. You'll have ketones spilled if blood glucose is over 300, which I sort of alluded to as setting them up for DKA. Monitor intake and output. Again, make sure you're doing your liver and your renal panels. Administer as prescribed. Important to make sure it's being prescribed correctly. You'll have drug books on the floor, so you can always go in, and you have drug guides in your medical EMR resources via your resource center as a nurse in hospitals. So you're gonna, if you don't know something, go look it up. If you don't know, go ask. Don't go just giving it. I think it takes a village to do things right, and not just be universally by myself all the time. I think this is pretty much the last. So I'm going to have you look at this because it's self-explanatory. You can go to your Nurse Practice Acts as well, and you can look up insulin for these items, and especially your facilities. That's probably your primary first choice because they are paying you to take care of your patients. You can read that. It's pretty self-explanatory. That's pretty self-explanatory. That's pretty self-explanatory. I think you got this. I really hope you enjoyed this lecture. I hope it added some content from Nurse 112 for you. You'll see a lot of this is more going to fall back now on hypertension and beta blockers and cardiac. So you may want to come back to this slide periodically when we get to perfusion in week 6 and 7. Teach, 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 educate, 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 and educate again, and get them to get bracelets. This is reiterating what we've talked about. And that is that. So that took an hour and 7 minutes. That's not bad. That's better than sitting in the 3-hour class listening to me jabber on. Your posting voiceover PowerPoints will be available through the appropriate module, and they will show up at some point today. The voiceover PowerPoint orientation's done. This is lengthy, so it's going to take a while to process and upload, and the uploads are going to go straight through to YouTube. So whatever voiceovers I do, you will have them available to you even after you graduate, especially if you want to go back and review as you get ready for boards. I will do, based on time and my administrative work, to do PowerPoints voiceover. I think I get it. I understand that having some meat and a voice to the content is much more of a learning experience but I'll do the best I can. I love to teach. I love to be interactive with students. But I will do the best I can. Okay? Have a great day. If you need anything, shoot me an email. Bye.